This is being conducted by North Bengal Medical College with very good hand and very good helpful presentation throughout the year, which I have at least got from Dr. Madhumita. And she is very enthusiastic, and she has helped me throughout the year, giving different tips regarding these meetings. And I now hand over the presenter, Dr. Satyabroto, for conducting the rest of the meeting.
Very good evening, everyone. On behalf of North Bengal Medical College, I welcome you all to this IP clinical meeting. And without wasting further time, I would like to invite Dr. Bengal Rai for his first presentation.
Thank you for the opportunity. Good afternoon and a very warm welcome to everyone present here. I am Dr. Bengal Rai, first year postgraduate resident at Department of Pediatrics, North Bengal Medical College and Hospital. Today, I would like to begin this clinical meet with a very interesting case that provided ample scope of learning to us. Now to begin with the presentation. A six-year-old boy from North Dinajpur, West Bengal, presented with complaints of fever for the last 7 days, dry cough for the last 6 days, and left-sided chest pain for the last 6 days. Respiratory difficulty was also present for the last 2 days. There were no history of TB contact or any significant weight loss in recent months or any hospital admission due to similar kind of illness. There was also no history of handling of a pet animal. The child was immunized up to date as per the national immunization schedule. There was no developmental delay in this child, and he and his family belong to the upper lower class. Now coming to the clinical examination part, the child on examination was alert, conscious and playful, and there was mild pallor present. Anthropometry and BMI was normal as per his age, and his vitals were stable at the time of presenting to us. Now coming to the systemic examinations, all of the systemic examinations, mainly the CNS, the CVS and the GIT examination, were all within normal limits. But in the respiratory system part, we found that the child had tachypnea, the trachea was at midline, apex beat had not shifted, and vocal fremitas and vocal resonance was both reduced on the left side of the chest. There was reduced air entry on the left, median and lower side of the chest, and the percussion was dull. To summarize this clinical informations, a 6-year-old boy presented with fever, cough, left-sided chest pain, and respiratory difficulty to us. On examination, mild pallor was present. There was reduced air entry on the left side of the chest, and dull note was found on percussing the left side of the chest. With this clinical information in the background, we have arrived at some provisional diagnosis. This might be a case of left-sided consolidation of lung. Left-sided pleural effusion might also be present, and it might be a case of left-sided lung mass. Now we will proceed towards necessary investigations. We initially went forward with the chest X-ray in this patient, which revealed a rounded homogeneous opacity that was present at the left middle and lower side of lung, which had its convexity upwards, and there was also clearance of the left costophrenic angle. So according to the particular chest X-ray, it might be a pulmonary mass lesion. To confirm our suspicions, we also screened the thorax and the abdomen with ultrasonography, and the USG thorax screening revealed a 12 by 7 cm square anechoic cystic SOL was present at the lower lobe of the lung, and tri-layered coverings was present. So the USG features are suggestive of a cystic lesion of the lung. We also screened the abdomen with ultrasonography, and it revealed, to our surprise, a presence of a similar type of cystic SOL at the right lobe of liver with thickened wall and tri-layer covering. So it might also be a cystic lesion of the liver. Now to aid our diagnosis, we went forward with the CT thorax and abdomen. The HRCT thorax revealed the presence of a 120 by 72 by 60 mm cube thick walled uniform cystic lesion without any loculi that was present at the left side of the lung and along with the collapse of the left upper lung. The CT finding suggests this to be a probable case of a hydatid cyst, but no confirmatory diagnosis has been made yet. The CT abdomen also revealed the presence of a similar kind of lesion at the right of liver that measured around 63 by 60 by 60 millimeter cube. This was also suggestive of a hydatid cyst of liver. We went forward with some routine investigations and it revealed the presence of mild anemia and mild eosinophilia in this patient. Next, to finally confirm our diagnosis of this being a case of a hydatid cyst, we went forward with serum Echinococcus antibody IgG, which came as a positive. So in a nutshell, all relevant clinical findings and radiological investigations suggest this to be a case of hydatid cyst of both lung and liver. Now, coming to the management strategies, to manage this particular case, we'll have to first classify this particular case according to the WHO classification of 2001, which broadly classifies the hydatid cysts into 5 broad subcategories according to the radiological findings, among which the stage CE1 and stage C2 are in active stages. Stage CE3 is transitional and the rest are inactive. Here is a pictorial representation of the particular classification that I have mentioned earlier. As you can see, it is mainly based on the USG, MRI, and CT findings of the particular cyst. So now if we compare the radiological investigations that we did in our patient and the findings that we got with the particular prototypes, we can very well see the particular case falls under the category of stage CE1 in both the cases of the lung and the liver. So it might be a case of lung and liver hydatid cyst stage CE1. Now, although both of the cysts are echinococcal in origin, but the management strategies differ in both of the cysts. First, in the hepatic cyst part, in stage CE1, we usually go with albendazole therapy at a dose of 15 mg per kg up to a maximum of 800 mg per day. In case of cysts that measure more than 5 centimeters, we opt for puncture, aspiration, instillation, and reabsorption, in short PAIR, with albendazole therapy. Now, the management of pulmonary hydatid cyst is different from that of the hepatic one. It is mainly of surgical origin. And there are multiple avenues to approach a case of pulmonary hydatid cyst, and we have few options available to us. The options are enucleation, pericystectomy, cystostomy with capitonage, segmental resection, and lobectomy. Among which the cysts which measure more than 10 centimeters in size, lung resection is the most feasible option. As you can see from the particular options, that PAIR is not an indication in case of pulmonary cysts due to its complications. To manage our case, as the pulmonary, or in broad terms, extrahepatic cysts are contraindicated to undergo PAIR, tablet albendazole is being given to the child at a dose of 15 mg per kg in this case, and it is being referred to a CTVS surgeon for the surgical considerations in case of the pulmonary counterpart of the cyst. For the hepatic part, the case is being discussed with the Department of General Surgery here at NBMCH for the feasibility of PAIR in our setup. So the whole management is still ongoing, and we are currently following up the treatment as we speak. So in conclusion, in our practice, we often come across various pulmonary cystic or mass lesions that are easily confused with other different pathologies like pleural effusion or any mass lesion, and simple imaging modalities like USG or chest X-ray can become very useful in these situations. Talking of hydatid cysts, although liver remains the most common site of hydatid cyst formation, lung is also the second most common site, following the liver. Of patients with lung cysts, 20 to 40% also harbor liver cysts, just the case that our patient presented with. Thank you all. And with this, I would like to conclude my case presentation.
Thank you, Dr. Bengal, for this nice presentation. And now I would like to invite Dr. Shobboshachi Kaji for the next case. Any question? If there is any question, they can be put in the chat box. We will answer them subsequently.
A very good afternoon to all respected delegates present, my teachers and my fellow colleagues. Myself, Dr. Shobboshachi Kaji, a first year
Kaji,
resident.
your screen, your presentation is not open. Open your presentation.
The slides are not visible yet.
You first stop sharing the previous one and then you open your presentation.
A very good afternoon to all respected delegates present. Myself, Dr. Shobboshachi Kaji, a first year resident, Department of Pediatrics, North Bengal Medical College. As we can see, the theme of my presentation today is to think beyond pneumonia. Now, as a pediatrician, we come across several cases of pneumonia in our day-to-day life, but sometimes we do need to look beyond and find any underlying condition is present or not. With this, I would like to proceed with my case.
Is it coming? Is your what about others? Other participants? Your screen is
Yes,
PPT is not
visible.
A 5 years old.
PPT slides are not visible.
Slides are visible. Madhumita.
Visible,
Slides
no?
are-
Okay.
Yes,
okay,
yes.
okay, then it's
Slides
okay.
visible, slides visible.
Thank you. Thank you.
Go ahead.
A 5 years old female child from Jalpaiguri district presented to us with low-grade intermittent fever for last 1 month, shortness of breath for last 10 days, along with intermittent bouts of cough for last 1 year, with sputum production for last 6 months. On our primary assessment, the child's airway was maintained. The child was tachypneic with respiratory rate being around 50 per minute, nasal flaring and chest retractions were present. Saturation at room air was 80% in propped up posture and bilateral coarse crepitations were heard. The patient was also tachycardic with heart rate being around 130 per minute, blood pressure being around 90/60. Neck veins were found to be engorged and mild tender hepatomegaly was noted and gallop rhythm was heard. The patient was alert and conscious and temperature was found to be raised at around 102 degree Fahrenheit. So on our primary assessment, it was a case of pneumonia with signs and symptoms of heart failure, and the patient was immediately shifted to PICU and managed with high flow nasal cannula oxygen at 2 liters per minute, with FiO2 being around 60%. Fluid restriction was done, and injection furosemide at 0.5 mg per kg was given, and due to raised temperature, paracetamol was also given. Going back to the past history of the patient, she had recurrent episodes of fever, cough, and cold since 1 year of age, which required treatment with oral antibiotics. Also, there was 2 episodes of hospitalization, which required treatment with IV antibiotics. The patient was immunized up to date according to national immunization schedule. There was no significant family history, and the patient belonged to lower middle class family. Also, there was no contact history of tuberculosis. On examination, the patient was found to be moderately stunted. Mild pallor was noted. Grade 2 clubbing was found. No lymphadenopathy was present. Mild tender hepatomegaly was noted as mentioned earlier. Also, there was no splenomegaly. Initial investigations revealed a high total leukocyte count, which was predominantly neutrophilic. CRP was found to be elevated and HIV was ruled out. On performing a chest X-ray, it shows a bilateral patchy heterogeneous opacities, which typically resembled a bronchiectatic picture. Due to a high clinical suspicion, we decided to go for an HRCT thorax. And HRCT thorax resembled a classical signet ring appearance, which is pathognomonic of cystic bronchiectasis. Echocardiography revealed a mild tricuspid regurgitation, which was most probably due to secondary pulmonary hypertension. Now, what could be the cause of this bilateral diffuse bronchiectasis in this 5-year-old child? Now, in a country like India, tuberculosis had to be ruled out. So Mantoux test was done and it came out to be negative. Sputum for CVNR sample was sent twice and at both times it came out to be negative. As mentioned earlier, there was no contact history of tuberculosis, and the clinical presentation and the extensive bilateral bronchiectasis makes the diagnosis of tuberculosis very unlikely. Number 2, cystic fibrosis. CFTR gene analysis was done for 5 codons and it came out to be negative. Also, there was no history of frequent greasy, bulky, foul-smelling stools or trouble in having any bowel movement. Sweat chloride test could not be done due to limited resources. But going by the history of the patient, cystic fibrosis is a strong possibility and it cannot be excluded completely. Congenital immunodeficiencies. Having already ruled out HIV earlier, we decided to plot a serial hemogram, and it shows a gradually decreasing trend in the total leukocyte count, which was also predominantly neutrophilic. There was no evidence of neutropenia, no evidence of lymphopenia or leukopenia. Platelet count and morphology was normal. So serial hemogram did not suggest any specific disorder. Immunoglobulin profiling was done and serum IgE was found to be elevated, more than 1000. So could it be hyper IgE syndrome? Usually in hyper IgE syndrome, IgE levels are more than 2000. Also, there was no recurrent history of recurrent skin infections, eczema, dermatitis, nor there was any history of empyema present. Flow cytometry revealed a decrease in the number of nascent cells. Our next DD is primary ciliary dyskinesia or Cartagena syndrome, but there was no history of recurrent middle ear infections, no history of rhinosinusitis, nor there was any evidence of situs inversus, making the diagnosis of Cartagena syndrome very unlikely. Now, coming to the etiology of the patient, going by the history, cystic fibrosis and congenital immunodeficiencies are two strong possibilities. And with the current set of investigations, we cannot completely rule them out. So our future plan of investigations is to perform a sweat chloride test, or exocrine pancreatic function test like stool fat estimation, flow cytometry for B cell, and genetic test for hyper IgE. Coming to the management, infection control to treat exacerbations was a primary motto. So blood and sputum culture was sent, and blood culture came out to be positive for Staph aureus, which was sensitive to vancomycin, and sputum culture was positive for Pseudomonas, which was sensitive to piperacillin, tazobactam, and colistin. Now, by the history of the patient of recurrent chest infections, we decided to do a blood galactomannan test, and to a surprise, it came out to be strongly positive, suggestive of invasive aspergillosis. So patient was given injection vancomycin and piperacillin tazobactam for 28 days. Colistin nebulization was given, and also IV amphotericin B was given for 28 days. And the response of the treatment was followed up clinically and laboratory parameters like hemogram and CRP. Number 2, airway clearance techniques. Regular physiotherapy and postural drainage procedures were suggested and started after stabilizing the patient. These procedures were also demonstrated to the parents so that they can continue at home. Nutrition, calorie-rich diet was prescribed after consultation with the dietitian, and also fat was supplemented to make it calorie-rich. Mucoactive agents were used. Hypertonic saline nebulization was started during hospital stay. Also, inhalational budesonide with spacer was started, and it was continued as home management. As home management, the patient was discharged on oral antibiotics, azithromycin 10 mg per kg per dose 3 times a week to reduce the recurrent pulmonary exacerbation. The patient was followed up after 1 month, and she was doing clinically well. Lab parameters like CBC, CRP was within normal range. Now, our take-home message today is often it is not possible to come to an etiological diagnosis of bronchiectasis, as several studies have shown, but that shouldn't hamper the treatment process of the patient. A holistic, multidisciplinary, and timely approach can improve the quality of life of the patient significantly. With this, I would like to conclude my case. This is a recent picture of the patient showing a happy family. Thank you.
May I ask a question?
Yes, sir.
To Subhashachi?
Yes.
So many costly investigations you have done, and but a simple test like sweat chloride couldn't be performed. Is there any explanation to it?
So sweat chloride test couldn't be.
Sweat chloride test is not performed in our institution, and in North Bengal it is not in small children. It is not performed in private setups also.
Dr. Satyabrat, another question. This CFTR gene analysis, was it done in your institution?
No, sir. This was not done in our institution, but it was done in collaboration with Swasthya Sathi program.
Okay. So the final diagnosis is not yet available?
No, sir. We are planning to do. There was hyper IgG level was high, but it can also be due to the aspergillus infection. But in invasive aspergillosis, IgE also high, but it's also more than 5,000. Okay, but we have consulted this patient with PGI Chandigarh, and the party is also eager to evaluate that there, and we are considering to do some genetic test for hyper IgE, because some DOC2 mutations can cause this type of presentation in some patients, but it is not very clear presentation for hyper IgE. So there are lots of confusion with these patients, and we're trying to evaluate and consult this patient with PGI.
Sure. Next case.
So thank you, Dr. Kaji. Now I would like to welcome for next presentation, Dr. Sharupanando Bera, and his presentation is matter of the mouth.
শোনা যাচ্ছে না।
Is the first presenter present still, Bengal?
Yes, sir.
Bengal is here still?
Yes, Bengal is here.
The second, okay, let's go the second case, then I'll come to the point. Matters of the mouth. Sorry,
ফুল স্ক্রিন করে দিচ্ছি। বুঝেছো?
Good afternoon, everyone. I am Dr. Sarvananda Vera, first year PhD, Department of Pediatrics, North Bengal Medical College. I want to discuss two interesting cases. My first case is 12-year-old boy presented with low-grade fever for last 1 month, which is intermittent in nature, evening rise of temperature, and cough for last 10 days, and chest pain during both inspiration and expiration for last 5 days, breathing difficulty for last 2 days, and also difficulty in opening mouth for last 2 weeks. On examination, we found pallor, fever, and tachypnea. Other findings are within normal limit. According to anthrometry, we found OST.
Please go back to the first slide, second slide. Multiple insignificant. Okay, go on.
As a background of low-grade fever, cough, chest pain, and significant weight loss, we are suspecting this is a case of pulmonary TB. So we started investigation. We found anemia, ESR greater than 100, and CRP also raised. Mantoux test positive, but chest X-ray is normal, and sputum for AFP negative, and sputum for CB also negative. So possible diagnosis is pulmonary TB, but point in favor of pulmonary TB is history suggestive of pulmonary TB. Mantoux test is positive, ESR greater than 100, but point against pulmonary TB is chest X-ray normal, sputum for AFB negative, and sputum for CB also negative. So dilemma: should we start ATD or not? One complaint I have not discussed earlier, that is difficulty in opening mouth for last 2 weeks. So we started thorough examination. On examination, we found tenderness and restriction of movement on TM joint, and patient can put only 2 fingers in his mouth. Are we dealing with rheumatological condition? Point in favor, TM joint pain and past history of knee joint pain for last 2 years for certain duration. But point against is no history of rash, alopecia, oral ulcer, and Raynaud's phenomenon. So we started tablet naproxen. Patient improves dramatically. Chest pain and respiratory stress also improve within 5 days, but TM joint movement restrictions still persist. So we suspecting this is a rheumatological condition. We sent for ANA and ANA profile. ANA is positive, found fine speckle pattern on ANA profile. Anti-SCL70 positive, anti-SSA positive, anti-RNP antibody also positive. So anti-SCL70 is very much suggestive of scleroderma. So we send the scleroderma profile also. On scleroderma profile, we found multiple autoantibodies positive like anti-centromere, anti-RNA polymerase 3, anti-PM-SCL75, anti-fibrillary also positive. The anti-dsDNA, but anti-dsDNA is negative. Serum C3, C4 is normal. RF factor is negative. So possible diagnosis is rheumatological disorder. So rheumatological disorder is a multi-system involvement there. So we started system-wise thorough investigation. HRCT thorax, we found fibrotic band in left lung. On echo, grade 1 diastolic dysfunction found. But USG whole abdomen is normal, and 24-hour urinary protein creatinine ratio also normal. So we found SLE-like manifestation like past history of knee joint pain for certain duration, but no history of rash, alopecia, oral ulcer, and autoantibody like ANA positive, anti-SSA antibody is positive, and SCL systemic sclerosis like manifestation like difficulty in opening mouth for last 2 weeks, but no history of skin tightness, sclerorectally, and no history of Raynaud's phenomenon. On HRCT thorax, we found pulmonary fibrosis and multiple autoantibody like SCL70 and anti-RNA polymerase 3, anti-centromere positive. So here we found few clinical features suggestive of SLE and systemic sclerosis, but multiple autoantibodies are positive. So my provisional diagnosis is overlap syndrome, most probably mixed connective tissue disorder and disease in evolution. So we started tablet prednisolone and tablet HCQ. So we are in regular follow-up this case to see the clear picture in the future. My second case is 11-year-old girl presented with pain and stiffness of small and large joint of hands for 1 year, and stiffness increased during mainly morning times. Recurrent episode of low-grade fever for last 1 year. Raynaud's phenomenon for last 6 months, and skin tightness for last 3 months. Alopecia and recurrent oral ulcer for last 3 months. Extreme fatigue and exhaustion for last 2 months. Dysphagia to both solid and liquid food for last 1 month. Pain and stiffness of TM joint for last 1 month. On examination, only pallor is found. According to anthropometry, we found wasting. On musculoskeletal examination, tenderness and stiffness of MCP joint, PIP joint, wrist joint, elbow joint of both hand found, but no swelling and redness of joints. Also found tenderness over TM joint, but no axial joint involvement. On investigation, we found anemia and ESR also raised. ANA positive, coarse speckle pattern, anti-RNA polymerase 3 positive, anti-RNP positive, and we found anti-dsDNA also positive. But serum C3, C4 is normal, RF factor is negative. We started investigation system-wise, and on HRCT thorax, we found fibrotic band in both lungs. On echocardiography, we found mild tricuspid regurgitation, USG whole abdomen normal, and 24-hour urinary protein creatinine also normal. So here we found SLE-like manifestation like polyarthritis, recurrent oral ulcer, and alopecia, and autoantibody like ANA positive, anti-dsDNA also positive. Systemic sclerosis-like manifestation like Raynaud's phenomenon, dysphagia, and skin tightness, and autoantibody like anti-RNA polymerase 3 also positive. So now here we found multiple clinical pictures shows SLE and systemic sclerosis-like manifestation, but few antibodies are positive. So we found here SLE-like manifestation and also systemic sclerosis-like manifestation, and also anti-RNP antibody is positive. So my provisional diagnosis is mixed connective tissue disease. So we started tablet prednisolone and tablet HCQ. here anti-DSDN is positive, so we plan for renal biopsy, and final treatment plan decided after renal biopsy. So sometimes it is not possible to reach a diagnosis for a specific connective tissue disease in a specific patient in a specific time. So we can put them in some groups like undifferentiated connective tissue disease. Here, patients do not meet the criteria for a particular autoimmune disease. And number 2 is overlap syndrome. Here, meeting the criteria more than one classical autoimmune connective tissue disease. And within the overlap syndrome, we found a special type of disorder like mixed connective tissue disease. Here, anti-RNP antibody positive and had clinical features like SLE, systemic sclerosis, and polymyositis and rheumatoid arthritis like features. So all mixed connective tissue disorder is overlap syndrome, but all overlap syndrome is not mixed connective tissue disorder. Thank you.
Good case. Only one thing I want to ask you, Shoropanando, this Mantu is strongly positive. Can you explain it? And actually, Manti is not suggestive of any of tuberculosis. It actually signifies past infection with tuberculosis bacilli. And what is the strong possibility, strong Mantu positivity in this case?
So
You mentioned it's 20 by 22, isn't it?
yes.
Both the patients were immunocompromised as they're both suffering from MCTD or say scleroderma. And in this background, how can you explain this strong Mantu positivity?
So in India, it is very frequently patients are exposed to tuberculosis. Sometimes it is not overt tuberculosis, but before, as we are starting this patient on steroids for long term, we are very much cautious that patient is Mantu positive. So there may be some dormant tuberculosis focus that may flare up later. So we should we are keeping track of the patients for that reason also.
Actually, that was the question. Should we be giving anti-TB chemoprophylaxis or not? But as she is a bit grown-up girl, and then IP does say giving chemoprophylaxis, but we, as CB-NAT and other things, chest X-ray are not compatible with TB. So we have not given anti-TB drugs, but we'll be following up, like we'll monitor this child.
Yes.
There are chances that TB might Mantu positive is a sign of infection, not disease, but
Not disease.
may develop the disease later on also. So we have to keep in mind, and that's a nice thing that you have pointed out.
Okay.
And
But-
Madhumita,
Yes, sir.
can we do the IGRA test whether there is any scope of IGRA test at our college or outside the college?
Sir, IGRA value to आजकल बोलचे नहीं.
No.
May I intervene? Last
Yeah.
workshop NTEP at Medical College, actually both Mantu and IGRA were pointed out, and the presenter, he strongly condemned this. He said that this actually a lobby behind IGRA. IGRA is a costly investigation.
Yes, very costly.
And for a simple Mantu test is enough. So I think IGRA, we should not go for IGRA.
Actually,
No.
Actually, in children, IGRA, there is no specific recommendation regarding IGRA. As number one, especially for a developing country, poor country like us, doing a very costly. Rather, everyone says that if Mantu is positive, keep under follow-up, and if there are indications of chemoprophylaxis, then chemoprophylaxis you have to start. Or else, if the patient develops the disease, then we have to treat like that of a disease.
No,
And
I don't know.
speaking,
But
I also don't know if
Arudha bolo and what Arudha ki bolchile bolo shunini.
but in UK they need IGRA for the TB screening test. Recently, they have one of my known person
Relative.
He had gone to UK. They asked for the TB screening test, and their recommendation is IGRA.
Yeah,
So I
yeah,
don't know
you're
whether
right,
it is
sir.
correct or wrong.
Yeah, you're right, sir, but that is UK. But as like 1-2 is positive and most probably it's false positive, it's a sign of disease. So if we start doing IGRA also rampantly, and then there will be a very
Much
like a
confusion.
situation
It
like
is-
whom to treat and not to
it
treat.
is-
So our authorities do not recommend IGRA, especially in children, at least up till now. So I don't know, and it's not. It's very costly, and it's not done in our hospital outside also. Frankly speaking, we don't know. It's done not in North Bengal.
But thank to Sarbananda and his team for thorough investigation
hello,
of this
Madhumita.
sensitivity.
Madhumita,
Sir,
may I ask one question?
yes,
যেটা
sir.
তুমি বললে যে strong positivity of 1-2, we should
Yes.
keep in mind that there is a chance of flare of tuberculosis infection in later
Yes.
life. So
Yeah.
what's wrong if we start early treatment and then
No, early that will not be a treatment. That will be chemoprophylaxis.
Yes.
But
chemoprophylaxis or
yes,
preventive
sir.
treatment.
But official recommendation of chemoprophylaxis is age below 6 years and 1-2 positive. There is no localizing sign of tuberculosis. That is the official recommendation till now. Because
Then how
many
can you
of us,
explain the
many of
source?
us will be 1-2 positive if we get ourselves tested. So till now, at least the recommendation is that for chemoprophylaxis, children up to 6 years, if they are 1-2 positive without any localizing or signs or symptoms of tuberculosis, because
And
chemoprophylaxis regimen is something different from treatment regimen. And
Right.
if by chance, if there is a TB disease and not just infection, and doing like treating, giving just chemoprophylaxis, so that will be a subtherapeutic or below optimal dose of anti-TB drugs. So without proper recommendation, without proper indication of TB treatment, I don't think
there is
treatment
a
as
strong
such for TB
suspicion.
should be started.
But
Yeah.
there is strong suspicion that this patient may develop tuberculosis in
No, we
later
have
life.
to monitor that. We have to keep under close follow-up and monitor.
Because they are already
Steroid,
compromised and they are on steroids. They are immunosuppressants also.
Yeah, they will. No, now getting steroid, probably in future she will get more immunosuppressive drugs. Steroid বেশিও আরো কিছু দিতে হতে পারে। তখন
biological আসতে পারে, biological
Yes.
দেওয়ার আগে তো অবশ্যই screening করতে হবে।
না, সেটা পরের কথা, মানে দিতে হতে পারে।
Methotrexate সাথে আসতে পারে, অন্য কিছু আসতে পারে।
আচ্ছা,
Yes,
এটা
sir.
খুব ভালো হয়েছে। নেক্সট কেস।
So thank you, Dr. Sarbananda Bera. I would like to welcome Dr. Nikhil for his next presentation, Caught by the Clot.
Sir, am I visible?
তাহলে একটু ইন্টারফেয়ার করবো, ডক্টর রায় বলছি।
Yes, sir. Yes,
বলো।
sir.
হ্যাঁ হ্যাঁ,
It's
বলছি
quite
যে
visible, sir.
না, আচ্ছা এক সেকেন্ড। বলছি আগের যদি দুটো কেস প্রেজেন্ট করেছে, তার মার্কিংটা তাহলে কিভাবে হবে?
এই দিয়ে দাও, নম্বরগুলো দিতে থাকো। আমি তো দিয়ে দিচ্ছি তো।
না, ইন্ডিভিজুয়ালি তো এক একজন একটা করে, তো দুটো করেছে।
না, ওকে নম্বর তুমি 3টে সেকশনে ওই 3টে পয়েন্টই দেবে। তুমি নম্বরটা এখনই বলো না, তুমি দিয়ে রাখো।
সে দেবো না, কিন্তু ওর ক্ষেত্রে
আমি একটু জাজেদেরকে একটা কথা বলছি, নম্বর নিয়ে ডিসকাশনটা আমার মনে হয় না একটু আলাদা করে ফোনে করলে ভালো।
ঠিক আছে,
এটা সামনে না বলাই ভালো।
ঠিক আছে,
ওকে, নেক্সট প্লেস প্লিজ।
Sir, ওটাতে চলে আসো।
Sorry for the interruption. There is some problem with this slide sharing with this computer. We are just changing my computer with this computer.
It's coming now.
Yes, caught. The name is very catchy. Caught by the clot.
বাসুদা ফর্মে আছে মনে হচ্ছে তো।
আমার ক্লিনিক্যাল মিটিং খুব ভালো লাগে। এই ক্লিনিক্যাল মিটিং
বাসুকি জাজ আছে।
হ্যাঁ,
এই
জাজ আছে।
না, আমি আমরা কি No,
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 if
it's a-
there is any prize for regularly
Yeah,
attending
ওইটা-
clinical
Yes.
week, that
আচ্ছা,
should go to
এই-
Dr.
এই
Paul.
এই মধুমিতা একটা জিনিস বলতে
Yes,
পারি,
sir.
এরা
And
এরা
he
যে
should get
এই
the prize.
না না আমাকে ওই প্রাইজ দিতে হবে না, কিন্তু টিভি নিয়ে প্রচুর ওয়ার্কশপ হয়েছে, আর
হ্যাঁ।
একটা হওয়া উচিত, কারণ এরা আমি দেখতে পাচ্ছি অনেকেই এই কেমোপ্রোফাইল্যাক্সিস সম্বন্ধে সঠিক জানে না। এখন কিন্তু অ্যাডাল্ট কেমোপ্রোফাইল্যাক্সিস চালু হয়ে গেছে, এটা একটু আমার মনে হয় একটা এনটিপি ওয়ার্কশপ করা
হ্যাঁ,
উচিত।
হ্যাঁ, এনটিপি হচ্ছে, মানে তো অনেক জায়গায় হচ্ছে।
আর একবার
আচ্ছা
করতে
স্যার,
হবে।
আমরা নেক্সট কেসে যাই।
হ্যাঁ হ্যাঁ, কট ব্যাক ক্লট
হ্যাঁ,
স্লাইডস আর
Dr.
ভিজিবল।
Nikhil.
ওকে,
Nikhil, if you are ready, you can start.
So Nikhil, please start.
কি হলো? Where is Nikhil?
আমার মনে হয়
স্লাইডস আর
slides
হলো?
are not moving.
slides are not
share
moving.
হচ্ছে।
Yes, slides are not moving.
Slides are not moving.
সোমনাথ দা,
এই তো,
yes.
move
It's a
করেছে।
call.
right.
So, but Nikhil is not visible. Shotto, what happened?
Okay. Hello, ma'am. Am I audible, ma'am?
Yeah, you're audible. Proceed.
So today I'll be presenting another interesting case, which is more relevant in the post-COVID era. We have named this case "Caught by the Clot." So let's unfold this case. So we had a 5-year-old boy who presented to us with a history of fever for the last 6 days. He also complained of generalized body ache and pain abdomen for the last 6 days, with redness of eyes for the last 4 days, and progressive respiratory distress for the last 24 hours, for which he had to get admitted. He had no previous histories of headache, rash, joint swelling, sore throat, or any similar illness in the past. The child was apparently well before these episodes, with no similar complaint in the family members, and the vaccination was also up to date.
No.
On initial examination, the child was alert, conscious, with visible respiratory distress. On examination of the vitals, the heart rate was increased to 148. The respiratory rate was also increased to 47. He was maintaining a saturation of over 90% with moist O2. The BP was within 50th percentile for the age. Temperature was elevated and the pulse was rapid and hypovolemic. This was the EBG of the child, which was more or less within normal limits. Shifted on systemic examination, we found that the child has had tachycardia with soft end hepatomegaly, with S3 gallop and bilateral basal crepitations. There was tachypnea with use of accessory muscles. The mediastinum was mid-like with bilateral air entry. There were fine basal creps, but no wheezing, stridor, or bronchial breath sounds. With this initial assessment, we shifted the patient to PICU and did some point-of-care investigations. This was the echo, which showed hypercontractile cardiac chambers, dilated IVC, and multiple B lines on both sides of the chest. And this was the X-ray of the child, which showed cardiomegaly and bilateral pulmonary hyperemia. So with this initial findings and examination, we had a provisional diagnosis of viral myocarditis presenting as heart failure, but we had some important differentials in our mind, like dengue shock syndrome, MISC, Kawasaki shock syndrome, acute traumatic fever. And with this differential in our minds, we started the child on inotropes, and all the relevant investigations were sent accordingly. On the initial investigations, the CBC showed hemoglobin of 8.9. The platelets were also decreased. There was neutrophilic leukocytosis. The urea, creatine, sodium, potassium were all within normal limits. The liver enzymes are within normal limits, but the albumin was reduced to 2.2 and INR increased to 1.12. For excluding MISC, the COVID IgM send showed very high titers of 682, though the RT-PCR was negative. The inflammatory markers CRP and PESR both were elevated. The topical infections like dengue, typhoid, scrub, and leptospira all came back negative. The CPK was within normal limits, though the LDH was elevated to 584. The D-dimers and ferritins were also elevated to very high levels. And the blood culture came negative. So to summarize this case, this 5-year-old boy who presented to us with fever and acute onset heart failure, who had neutrophilic leukocytosis, thrombocytopenia, elevated CRP ESR, whose blood culture were negative, so was scrub and dengue IgM reports. He had elevated levels of D-dimer and ferritin, hypoalbuminemia, and we found a positive COVID IgG serology. So as we can see, He fulfills the criteria of MISC. And with the diagnosis of MISC in our hand, we started the child on methylprednisolone and aspirin. After starting methylprednisolone on day 3 onwards, the tachycardia gradually decreased, the pulse volume improved, showed in the shock. We gradually tapered the inotropes and IV fluids were omitted. The frequency of fever decreased, but it persisted. On day 3 on day 4 onwards, with clinical improvement, methylprednisolone was tapered from 20 to 1 mg per kg. We took a cardiology opinion and we requested sir for a transthoracic echocardiography. The transthoracic echocardiography, as shown here, showed low ejection fraction, left ventricular ejection fraction of 54%. The coronary arteries were within normal limit. There was tricuspid regurgitation, but the striking and unusual finding was the presence of a mass in the right atrium. A large mass on the right atrium, which was very likely to be a thrombus. Since we came across this unusual finding, echo finding in MISC patient, so we had to look back into the literature, and we came across with various articles. The first article was showing that MISC as a prothrombotic state in pediatric age groups. There have been case reports of radial artery thrombosis, mesenteric artery thrombosis, and even cerebral artery thrombosis in patients of MISC. We came across multiple case reports of intracardiac thrombosis in COVID patients. But to the best of our knowledge, we could only come across single case of left ventricular thrombus in a 17-year-old child with MISC. So with this finding, we started the child on enoxaparin, 1 mg per kg BD, which is the therapeutic dose of enoxaparin in MISC patients. On day 9, the child has clinically improved. He was afebrile. Repeated echo showed an improved ejection fraction of 67%, though the mass persisted. The child was discharged on day 11 with tapering doses of prednisolone, aspirin, and enoxaparin with a plan of cardiac MRI. So, as we are all aware that thrombotic complications are very prevalent in adult COVID patients, but are less frequently reported in pediatric age group. In pediatric age group, though, MISC is a prothrombotic state. And since we are living in this post-COVID era and coming across increasing number of MISC patients where cardiac complications are a serious and very common phenomena, we should always suspect thrombosis in all patients and judiciously use anticoagulants in these patients. Thank you. That will be all. Sorry.
Excellent.
Thank you, sir. Thank you, sir.
Thank you, Dr. Nikhil.
Okay, Mr.
Hello.
Yes,
So
sir.
in the differential diagnosis, they have kept rheumatic fever as one of the possibilities. Why is it so?
Sir, we have kept it in the last possibility, sir.
Yeah,
it was a last possibility, sir.
It is not actually fitting in this.
Yes,
sir.
it is not fitting at all.
Yes, sir.
I beg to differ because re-emergence of rheumatic fever is a discussion point now. We shouldn't ignore it.
No, but
Other features of rheumatic fevers were
not present.
So after the echo, sir, our differential changed. We had included infective endocarditis into our differentials after the echo, sir. So we excluded dengue, and sir, it was unlikely to be Kawasaki. Though it feels since it's fulfilled on the criteria of MISC, and we know there is cardiac complication is very common in MISC. Patient present with left ventricular ejection dysfunction, left ventricular dysfunction, myocarditis. So we treated the patient with MISC, sir.
There is a question from Dr. Debashish Bandopadhyay. He has asked, was ECG done or not? Nikhil?
Yes, we did an ECG, sir. I did not present the ECG. We have done the ECG. It did not show any rhythm abnormality or any gross abnormality, sir. It was within normal limits, sir. We were looking for myocarditis, features of myocarditis in the ECG. We did an ECG with myocarditis in our mind, sir. But the ECG was within normal limits.
So if there are no more questions, Dr. Shotto, can you proceed to?
Thank you, Dr. Nikhil.
Okay, sir.
I welcome Dr. Devargho Pan for the final presentation of today's clinical meet. So, Dr. Pan, the screen is yours.
The screen is yours.
Just a second, sir.
Yeah, the screen is yours, not the stage. Here the screen is the stage.
Yes, excellent. collaboration cures.
Is my screen visible, sir?
Yes.
Faculties? Okay. First of all, apologies from our end for this mess up event regarding the setup of internet and all. We tried to make our best with the connections available here. Okay. So let me start now. Good afternoon, delegates. I'm Dr. Devargho, second year resident, Department of Pediatrics, North Bengal Medical College and Hospital, and the final presenter for today's session. Through my presentation today, I would like to reiterate once again upon the fact that at the end of the day, we are all doctors, and it is only up to us through our sincere efforts, hard work, and more importantly, a good teamwork that we can do wonders for our patient, even the critically ill ones. And that's what brings me to my case, which I have titled Collaboration Cures. So going into the case, we find an 8-year-old girl, lean and thin built, residing at Charsha Tea Garden, coming to our hospital with chief complaints of unresolving pain abdomen for the last 14 days and an acute onset respiratory distress, which was so progressive in the last 2 days that on presentation, the child's vitals were absolutely unstable. Though her airway was absolutely secure, her breathing was compromised in the form that the child was tachypneic. There was reduced saturation in room air. Air entry was reduced on the left, so was the movement. There was dull percussion note on the left side. The circulation of the child was also compromised in the form that capillary refill time was prolonged, urine output was reduced, the child was tachycardic, pulse volume was low, peripheries were cold. As she was starting to get lethargic, we did not take any risk as bed was available. We put her on oxygen, IV fluids, and directly shifted her to the PICU. And of course, in the PICU, we could easily do a bedside ultrasound, which was closely followed up by a bedside X-ray, both of which by this time clinically corroborated, did reveal a massive left-sided pleural effusion with mediastinal shift, for which we placed an ultrasound-guided ICD. Of course, the patient improved rapidly after the placement of the drain. However, in this entire stream of events, the only unusual finding was the color of the pleural fluid that was black. Whilst we waited for the analysis to come, we went back to the patient to take her detailed history about her chief complaints and learned that her pain abdomen was dull aching, was continuous in nature, periumbilical in location with radiation to the back, precipitating within minutes of food intake, relieved temporarily on stooping forward condition, was associated with nausea, vomiting, weight loss, anorexia. However, there was no history of diarrhea, jaundice, bloody stool, burning micturition with fever, any recent blood transfusion, worm infestation, greasy, foul-smelling stool, loose stools, trauma, or even drug intake. The respiratory distress, however, was acute in onset and sudden in progression, as stated earlier, over the last 2 days, and there was no history suggestive of any underlying or any pre-existing chronic cardiovascular or pulmonary disorder in the child. Now, the child did suffer from a similar episode of pain abdomen about 1 year back, for which she needed a hospital admission, but improved rapidly within 7 days of supportive management only. There is no history of chronic diarrhea in the patient as well. Contact history of TB is negative in this patient. There is no consanguinity, no similar illness in any other family members of this child. Socioeconomically, the child belonged to lower class, as well as which was reflected in her dietary history. She was deficient in both calorie and protein, as well as it was reflected in the anthropometry, where she was found to be underweight, wasted, as well as stunted. Now, proceeding to directly the systemic examination, we started off with the GI system. The abdomen was found to be tense. Tenderness, rebound tenderness, and guarding being present. Every possible examination could not be done. However, we could make out the presence of an ill-defined, soft, cystic, circular, tender, about 10 to 10 centimeter lump with obscure margins located around the periumbilic and on the umbilical region. So, hepatosplenomegaly as well. To summarize till this point, we got an 8-year-old lean, thin female child coming from poor socioeconomic background, presenting to us with continuous abdominal dull aching pain, precipitated within minutes of food intake with radiation to the back, relieved on stooping down, and with a soft cystic tender lump in the periumbilical region, presenting with sudden onset respiratory distress, which was revealed as a case of massive left-sided pleural effusion, stabilized with ICD insertion, with a similar history of pain abdomen about 1 year back, resolved spontaneously with with resolved with supportive treatment only. So from this clinical history, what we kept our working diagnosis for this case was acute recurrent pancreatitis with a local complication in the form of a suspected pancreatic cirrhosis and a systemic complication in the form of a massive left-sided black-colored pleural effusion. Etiology was still clinically unknown. However, the two unusual words again in this diagnosis was massive and black, because when we went back to literature to find out the association of pleural effusion with acute pancreatitis, we found out that it is pretty high as per the modern literature and is about 50%. However, most of these are only mild to moderate and not as severe as in our case. And second of all, black colored pleural effusion is also very rare entity and found in a few cases like aspergillus or metastatic melanoma or hemolysis after a massive intrapleural bleeding or a possible pancreatico-pleural fistula. Now, this actually rang our alarm bells. While we kept on managing the child with supportive therapy, an ultrasound whole abdomen was obtained, but it could not reveal anything other than what we already clinically diagnosed. So the routine investigations were also performed within this time. The CBC, electrolytes, renal function, serial CBG, ABG, LFT were all performed more or less well within normal limits, except albumin, which was slightly low. CRP also showed a decrease in trend. However, despite all this management ongoing, her serum amylase levels kept on increasing from day 1 to day 14, which proved that the disease was still not detected and it was ongoing. The CCT whole abdomen, which was obtained as a part of the protocol, could offer a better insight into the possible diagnosis. As it stated, there was a cystic fluid collection about 11 into 11.5 centimeter around the pancreas, communicating with the left-sided pleural cavity through the esophageal hiatus of the diaphragm. So this gave an impression of a possible pancreatico-pleural fistula. Now, as shown by the arrow. Now, by this time, we got the results of the pleural fluid analysis as came out to be exudate effusion, and with the possible diagnosis of a pancreatico-pleural fistula in our mind, we actually sent for the amylase lipase level once again, the pleural fluid, and not surprisingly, this actually came out to be positive in this case. So other investigations were also performed to rule out any possible etiologies of recurrent pancreatitis in children that we could do in our setup, like MRCP to rule out gallstones, worms, any structural anomalies of the pancreas. A lipid profile was sent to rule out the dyslipidemia, serum calcium, HIV, TB, all these things were ruled out. However, no any specific examination was found to be positive. So we kept our final diagnosis of this case as a case of idiopathic acute recurrent pancreatitis with massive pancreatic cirrhosis and a left-sided pancreatico-pleural fistula. Once the diagnosis was set, we looked for the treatment options available for this condition. And from literature, we learned that there are three main possibilities. One was pharmacotherapy with octreotide. Second of all, we could go for endoscopic or radio-guided percutaneous drainage, or finally, we could go for a surgical cystogastrectomy. Now, we did give a trial of octreotide, though there is no practical recommendation in children in any of the textbooks available, but it was not very effective in controlling the symptoms in our child. Endoscopic and percutaneous drainage, as mentioned in the text literature, recurrence rate is about 30 to 35, combining all the text, and it is not available in our setup as well. So the only possible thing that we could do in our setup, and is also the off-choice procedure in this case, was to go for surgical cystogastrectomy, and accordingly we did call a pediatric surgery consultation. But on pediatric surgery consultation, what we got to know was the minimum cyst wall thickness which is required for this surgery to even take place is about 3 to 4 mm, which was lacking in our patient, and it needed a waiting time of about at least 4 weeks for this patient to get this minimum thickness. So that is when we took up the challenge to keep the child in a proper build and nutrition, because she could not tolerate any oral feed. A strict asepsis was maintained, TPN was put, albumin and blood products were given as per the requirement of the child, and by God's grace and with our efforts, the child could undergo a successful operation. This was the intra-op picture of this patient, this empty cyst cavity, and luckily, and again through our efforts, the post-op period was also uneventful. Whilst slowly the feed was introduced, oral feed was introduced over 1 week, the patient could tolerate the oral feed this time. Pain abdomen gradually subsided. The sequential amylase lipase came down to almost normal levels by post-op day 15 of time. And sequential CT abdomen also improved from this being the pre-op picture to this being the post-op day 2 picture, to this being the post-op day 50 picture, we can see almost the cyst is gone. And the child went from doing this, a bedridden one, bedridden with a lot of invasive procedures on her entire body, lying in the PICU, pretty apprehensive, to this one roaming about, slightly confused, with holding her mother's hand with just one yellow cannula on her feet, which should not be done. And this brings me to the end of my case. And I would again like to end this session by saying, just reminding ourselves of this one word, that if we can all, we doctors can work together in treating our cases, and with our maximum sincerity and efforts, we can actually give a fresh lease of life to these kinds of patients and can help them and their parents give a better life. So thank you. Before concluding, I would just like to offer our special thanks to Dr. Rajesh Kumar, who is the Associate Professor of Pediatric Surgery, Department of General Surgery in North Bengal, without whose endeavor, without whose efforts, saving this life of this child would have been impossible. So thank you, sir. Thank you to all the delegates. Thank you.
Also well that ends well. Excellent presentation and excellent case.
Thank you, sir. Thank you so much, sir.
Thank you, Dr. Devargho. And there is a question in the chat box from Dr. Devabrata Sarkar. How to differentiate between acute recurrent versus acute and chronic pancreatitis?
Actually, if we go by the strict definition, in chronic pancreatitis, they have to satisfy actually two main criterion. One is the radiological criterion and one is the clinical criterion. But in acute recurrent pancreatitis, what they say is, in between 2 episodes of acute pancreatitis, the levels of amylase lipase normally comes down to normal level. So the keyword, I think, is the intermittent normalcy. I think, but I do not know if there is any exact difference between the two. What I have read is this much.
Any role of pancreatic enzyme supplements in subsequent days?
Actually, again, there is, I read up in the 2-3 available texts. I mean, most of these texts are available in the pediatric surgery guidelines. And what they actually say is, they once during the time of discharge, they actually asked to give pancreatic enzyme supplements. Though it was not chronic pancreatitis, actually, I have mentioned this American Pediatric Surgical Association, this guidelines actually states that they did mention there is some role of supplementing, but there is no evidence or head-to-head trial. I mean, like this kind in this kind of case, as far as I could find.
So
I think there is one more question from Dr. Riddhi, or some comment rather. She's commented.
So Dr. Riddhi has commented, I would suggest you to carry out CBG levels in this case, and it may be case of FCPD. Growth monitoring is important. Yes, so
yes.
We have done CBG monitoring.
Actually, the child did come back to us about around 2 to 2.5 months post-op. The child had actually gained weight by around 4 kgs from what we had discharged, and the anthropometric findings were also starting to improve. So we were slightly happy with that. But yes, we have to continue with diagnosing the cause of the recurrent pancreatitis. Why just instead of stamping it as idiopathic, right? Definitely, we have to as much as we can do. But since she belongs to a tea garden family, I mean, this is pretty difficult for her actually. But still, we'll try our maximum.
Thank you, Dr. Ghosh, for his encouraging comment in the box. And I think I don't have any more question in the chat box. So this was our final presentations. My heartfelt thanks from behalf of North Bengal Medical College to all dignitaries of the IPs and my seniors and my juniors. So I would like to end this presentation here, and mic is to the IP.
And before we conclude, I would ask Dr. Arup Rai, probably he is the senior most alumni from North Bengal Medical College, who is, we have got him as, he's participating, he's there with us. And Arup Rai, if you can
Yes.
একটা দুটো কথা যদি আপনার ছোট ভাইদের জন্য বলতে পারেন।
হ্যাঁ, এটা আমার খুবই পুরনো দিনের কলেজ। The pediatric department was established by senior Dr. Mary Chaku was there in the year of 1978.
বাবা কত বছর আগে
Long before.
But that time
And that
department
time
was
our
not
teacher
there.
was Dr. Ashish, and many all of us came. So I'm very much glad that all the PGTs have given the excellent presentation with the good feedback and question answering from our experts and judges. I thank you, Madhumita, and all the team members, Dr. Satyabrato, Rai Chaudhary, and others for the excellent CME or the clinical meeting from my own medical college. Thank you all. Only request, we are heading for the
অরূপদা কেটে যাচ্ছে,
no,
শুনতে পেলাম না।
just we are just one thing, we are heading for the neocon
Yes.
national neocon 2022 at December 1st to 4th. I am
Yes.
requesting all the PGTs and the faculties for the registration of the neocon. Nothing more. Thank you all.
Thank you, Arupda. So now over to Dr. Abhijit Doctor, as a representative from IAP. He's the scientific chairperson of West Bengal Academy of Pediatrics. And thanks a lot to all the participants who have made out this time to encourage the youngsters. They're relatively new to this clinical meat field.
Yes.
So they need encouragement. Our cases may not be as rare as other places, but we have actually, in our limited resources, we try to do our best. And today's 4 or 5 cases were just a few of those.
No, all are great
Thank
cases.
you.
Very well presented.
Thank you. And over to Dr. Datta.
Thank you, Madhumita, and your whole team. একটা excellent presentation হলো, power packed, compact. And thank you to the whole
endeavor.
team. Excellent endeavor, definitely. And in the same line as Dr. Arup Roy said, as a member of West Bengal Academy of Pediatrics and Hooghly Academy of Pediatrics also, it is just a gentle reminder that our next West Bengal State Pedicon will be held on 17th and 18th December in our own district, Hooghly, the main town, Chinsura. And I request Dr. Madhumita and all the faculties to definitely participate and to encourage your undergraduates and other members to come and join and enrich our West Bengal Academy of Pediatrics Pedicon. And now it's over to the judges for their scores.
আচ্ছা, অভিজিৎ, আমরা এখন তো ওপেনলি বলে দিতে হবে, কি করে বলে দিই? হাউ ক্যান আই?
না মধুমিতা, হ্যালো।
Yes, sir.
তো এই যে
স্কোরিং সিস্টেম,
অ্যানাউন্সমেন্টটা, হ্যাঁ, অ্যানাউন্সমেন্টটা কি ওপেনলি করবে না তোমাকে জানিয়ে দেবে তুমি পরে?
আমরা বলছি আমরা দুজনে আগে কথা বলে নি, দুজন জাজ, তারপরে পরে জানালেই সুবিধা নাকি?
You have to,
তোমরা নাম্বারগুলো তোমাদের নিয়ে যোগ করো।
হ্যাঁ, সে
আমার করা হয়ে গেছে। এই মধুমিতা,
হয়ে গেছে।
আচ্ছা শোনো, আমার কাছে মানে লাস্ট,
না শোনো বাসুদেব, 1 মিনিট। এইটা এই ব্যাপারটা কিন্তু তোমরা দুজনে ফোন করে ফাইনালি ব্যাপারটা মধুমিতাকে জানাও, তাহলে সেটা ভালো হবে।
সেটা কখন জানাবো? মানে
এখনই।
You have to select only one. As far as I know, only one. And the others, everyone will get certificates, but only one best presenter will get that distinction of the best presenter. So you won't need much time to do that. You select only one and tell
then,
us.
My vote goes to last case, that is Debargho Pan.
I am Dr. Amaru last candidate, Devargo Pan. He should
So
be-
if that is the consensus, then Dr.
unanimous decision.
একদম,
Unanimous decision, if that is the unanimous decision, then Dr. Dotto, as you are from IIP, you please announce formally the best presenter. But as far as I know, everyone will get certificates and all were good. Like
Everybody has excellent presentation. But,
Actually, his
according to the
presentation was
judge,
the best. Dr.
definitely
Pan's
it did.
presentation.
কিন্তু যেটা হয়েছে এই দেবার্গর ব্যাপারটা খুব একটা মানবিক আবেদন ছিল আর কি, মানে humanitarian approach।
fluid, খুব ভালো একটা। আচ্ছা,
প্রত্যেকেই ভালো করেছে।
একদম।
Thank you, Devargo, Dr.
Thank you, sir.
Devargo Pan, for your excellent presentation.
Thank you,
And
sir.
I think the follow-up of the case will continue, and আমাদের খুব ভালো লাগবে যদি আমরা এই বাচ্চাটার সম্পর্কে পরে জানতে পারি।
একদম স্যার, I have her contact number. I'll definitely
কারণ since she is from a remote place with poor socio-economic conditions and poor logistics facilities.
Actually স্যার এই বাচ্চাটার মানে কে বাঁচাতে পেরে we were মানে very happy, মানে more than the parents child.
তুমি যেটা বললে প্রথমে যে টিম ওয়ার্ক ছাড়া তো সম্ভব ছিল না। হ্যাঁ, টিম ওয়ার্কটা should continue.
Exactly, that point sir came and very dedicatedly he gave his time and efforts and everything. That is literally commendable. He actually came along with me. We together did the dressing for the child. I mean, this kind of endeavor is excellent. I mean, this.
So congratulations to all the speakers, and thank you. Gratitude to West Bengal Academy of Pediatrics for giving us this platform. Our PG students are very happy to have presented on such a state forum.
Yes.
So
এই
before
মধুমিতা,
this,
তুমি কবে প্রেসিডেন্ট হবে বলো আইএপি, এই ওয়েস্ট বেঙ্গল আইএপি।
so can we like meeting টাকে স্টপ করা যেতে পারে?